todos, good morning everyone.
Good morning.
Vamos a dar inicio a la segunda sesión
We're about ready to start the
relacionada con el
second
tema de
session
radiología.
having to
Esta
do with
sesión
radiology. And this
va a
session
estar dirigida, ¿no? O el título va a ser Búsqueda activa de tuberculosis
is
con
entitled
radiología
Active
y la
Tuberculosis Case
atención
Finding with
asistida por computadora.
Radiology
Y
and
vamos a
Computer
presentar las
Assisted.
experiencias exitosas de países de la región. Esta
Is from
sesión tiene
countries of the
como
region.
propósito, bueno,
This
presentar, como les
session
mencionaba ya,
aims at presenting experiences with the use of radiology, CAD, and also we're going to be talking about how to start or how countries have started this practice, what problems they have found, how the populations to be studied were selected using different CAD products, and we'll be talking about criteria for selection of post-action and what the results have been, as well as the lessons learned from implementation. We have interpretation in English and Spanish. At the bottom of your screen, you can see it says interpretation, or perhaps you have 3 dots. There you can choose either English or Spanish. Also, I want to say that today's presentations will be shared with you through a link that is being created. And then that way, all of these sessions, the past one, this one, can be shared with you. You'll have the recording, the presentations from the past and from today. Now, as an agenda, we're going to hear from Dr. Belkis Marcelin, who is part of the regional tuberculosis team here in Washington. She will be summarizing the previous session that was held in June, and then we will talk about active case finding using radiology and CAD. We will look at the experience of TB Mobile and TB Mochila, backpack TB, and that will be presented by Dr. Leonid Leka and by Daniela Puman, who is the coordinator of Partners in Health. After that, we're going to have a Q&A session so that you can ask the questions, make comments. You can send us your questions through the Q&A at the bottom of the screen. We will read those questions that we receive through the Q&A, and they will be answered. Then we will talk about active search, and there we'll be talking with Dr. Valentina Alarcón from Peru. She is the head of the National Tuberculosis Program in Peru. After that, we will hear about active TB case finding, and we'll hear from Paraguay. That will be presented by Dr. Sarita Aguirre, who is head of the tuberculosis program in Paraguay. Then we'll have another Q&A session, and at the end of the program, we will have closing remarks, and we will tell you about future events, future webinars on this topic. So I wanted to thank all of you for being here today, and on behalf of the regional team, and on behalf of Dr. Pedro Avedillo, who wasn't able to join us today, we hope that you will find this webinar helpful and that you can clear up any questions you may have. So go ahead, please, Doctor. Thank you, Nestor, and good morning, everyone. Thank you for being with us for the second webinar. And I wanted to remind you where we ended on the 11th of June, where we began this webinar series with a view to promoting active TB case finding in the region. And in this webinar, Dr. Avedillo was reminding us of the goals that were set in the high-level meeting of September 2023 and the key commitments, talking not only about coverage of treatment, which was 90% by 2027, as well as coverage of TB preventive practices, 90% by that same year. And to reach those objectives, we had to lower the gaps in detection and in treatment within the region. Also, in that presentation of Dr. Abadillo, he reminded you of the priorities that were set along with the heads of the tuberculosis programs, the priorities of eliminating TB in the region. And priority number one was to do active case finding, and also that we would work by finding hotspots. And there we would be using digital radiology and rapid molecular testing, and especially innovations such as artificial intelligence that would cover the CAD products. So we need information to be able to find those hotspots, the areas that have to be given priority and that have to be identified. And to remind you that the contacts are the most important players because they are the people that know about this exposure or that have this exposure. So we have to begin working on prevention with them. Also, number four was using short treatment cycles and all the treatment focused on a person's needs. Although it's number five, it's of equal importance. We have civil society, the communities involved, so as to be able to put an end to TB. And this series of webinars aims at making headway on these different objectives, the idea of finding cases and implementing prevention. Dr. Cecile from WHO, and she is here. Thank you for joining us. But in that first webinar, she talked about the guidelines, the evidence, and the operational manual for active case finding. She made a brilliant presentation and she covered the aspects, the evidence, different aspects, and for each risk group where the use of active case finding is recommended. The risk groups, remember, I remind you that is contacts with TB cases, persons living with HIV, persons deprived of liberty. And we have other groups that have clinical risk factors, other groups where they should be given priority by the communities. Now, all of that is in the slides that you will be receiving. And in the recommendations presented by Dr. Cecile, chest x-rays were recommended as a screening tool because chest x-rays are highly sensitive and they have great sensitivity, along with artificial intelligence, AI. When we talked about the operational manual, we heard about the documents that give us a step-by-step for national programs so that can guide us in finding cases actively. That manual gives us the 6 steps in this cycle of active case finding. First of all, assess the status of tuberculosis, doing a gap analysis, identifying the risk groups that will be found with this active search, and then put together a program establishing specific goals to close those gaps. Identify risk groups to be screened, also using the different screening algorithms, diagnostic algorithms with the tools that were presented, as well as the whole operational plan, as well as follow-up and evaluation. It's important to remember that the systematic search for people with TB is essential if we want to eliminate tuberculosis and cut off community transmission. Also, we heard about the indicators that we're going to be looking at in detail in webinar number 4. There we will be discussing all of the information systems aspects. Now, in the case of Sandra Goldfein, she talked about the screening tools that have been reviewed that are available now to do active case finding and to be used as a screening tool. We talked about the purpose, the use of the different categories, and the different types. I wanted to remind you, and that presentation talked about different X-ray devices, the ones that we use in health centers. These devices have high quality images. And I wanted to remind you that they can be moved, they can be taken to the community, and they can reach some places of very difficult access. The technology is chosen in keeping with the needs and the screening methods chosen by the countries. We also heard about the 12 AI products that we can find so as to have an assisted reading of X-rays, similar products with similar specificity, and you will be able to see with the information we'll be sharing with you the pros and cons of each type of device. And programs can choose amongst the 12 that are available, all of these different products. And any of the 12 that you choose will work well. The decision is more based on what you actually need. If you're screening only for tuberculosis, we have products that are only for TB readings. Or if you want products that can identify other pathologies, then we could also take that into account. The decision depends on what was identified as a screening method in the plan. Also, we heard about specificity and sensitivity. So we have a whole gamut of X-ray devices, and this gives us high precision diagnosis. Stop TB talked to us about the selection. It's important for the national programs to establish cutoff points when they begin to use AI. Then we talked about a series of webinars. This is webinar number 2 in the series, and we are going to be working on all of these issues in detail so that we will be able to support the implementation in the region, providing the region with success stories for active TB case findings. We'll be talking about the cutoff point, radiological safety, so as to be able to implement this technology. That will be on the 17th. And on the 30th, we're going to be talking about preventive treatment of tuberculosis. And this webinar, as Nestor was saying, we have asked our speakers to answer several questions. How do you get started? How do you select criteria? How do you select the population groups? And also to cover lessons learned. So as of now, for the 17th of July, put that on your calendar. There we will have webinar 3. It's called Radiological Safety, Selection of Cutoff Point, and those will be the topics. We hope that you will be able to join us for webinar number 3. So thank you very much. People are already asking, where are we going to be able to find those presentations? In just a few minutes, once we start with the presentations, we will be sharing with you a link. You can go into the drive and you can see the materials from webinar 1 and from today's webinar. And you can keep that same link. It will work for all of the virtual sessions. And for the webinar on the 17th, we hope to have the web page ready. There we will have all of the events, the recordings, the presentations, the documents that have been published, all of the links that we have mentioned on AI, on radiology, and all of the webinars that are going to be held this year and next year. So it's going to be put on one web page, and we will be presenting that to you during our next webinar. Thank you very much. Okay, I wanted to remind you that the questions can be sent to us through the Q&A at the bottom of your screen. I see that some people are raising their hands, but we're going to be answering questions through the Q&A. We have more than 150 participants in our session, and I wanted to say that in the previous webinar, the one on the 11th of June, we had more than 500 participants. This is a tremendously important diagnostic innovation for countries. So now we're going to call on the next speaker, who will be talking about active TB case finding with radiology. We'll be talking about the mobile TB and backpack TB with their names in Spanish, Mochila and Mobile TV. Can you hear me? Yes, we can. Great. Good morning. I'm from Partners in Health, and for more than 20 years, we've been working to fight tuberculosis in the country. We have been using AI and a diagnostic algorithm that allows us to detect on a timely basis those cases of tuberculosis in the country. Our first step was active finding in jails, in penitentiary institutions. And that was back in 2018. And there we introduced x-rays in penitentiaries, and they were read by an expert. And we did molecular tests that was used in most of these cases. And as you can see, there is a curve, there's an increase, an upward curve as of 2018. There you can see an increase in the reporting of cases of tuberculosis. Another important background datum is the experience in Karachi, in Pakistan. I just referred to the fact that we worked with penitentiaries, and that allowed us to identify cases. But then we thought that we needed to introduce another algorithm that would allow us to improve case detection. That is why, in basis of what we learned about Pakistan's experience of using these mobile units that you can see on the screen, we began to work in this way. Pakistan helped us. They gave us some tips so that we could dive into this world of active case finding. And even though all of this happened in Karachi, this is a place where they have the most mobile units of any place on earth. And through them, we were able to get funding through Stop TB. And there, in 2018, we won a competition, and with that, we were able to buy the first 2 mobile units in Peru. Now, here are the questions that I think most of you may be wondering about if you're thinking about doing active case finding. Where do you look? In what groups do you look? How do you look? When? Well, first of all, you have to take into account that all of these questions can be answered in different ways. A lot depends on your circumstances, the resources, the inputs that each country, each place may have. So where do we look? We looked in different areas, urban, rural areas, peri-urban areas. Some of you may be acquainted with Peru. You know that we have slums, favelas, and there we have low and high areas. And we had to determine where we wanted to look, where, and who are we going to be looking at. For example, we know that there are vulnerable populations, key populations, those deprived of freedom, but also other groups. So we knew that there was a lot of work to be done. Also, we wanted to know, okay, how do we come up with our algorithm? What is the best way to do this search? Do we begin with symptoms, or do we not ask about symptoms? That is what is done usually everywhere. So you're going to see the answers on the next slides. But one of the questions was, when? When do we carry out these activities? When do we do these things as we engage in this search? So back in 2019, we started in 3 districts to the north of Lima. Most of you probably know that Lima is the place where we have the highest burden of TB in Peru. So we chose the northern part in Caraballo. What we were able to do was in the first year, we were there 100%. Whereas in Comas, we worked in some of the districts. Our country has something like 33 million, and there the incidence is 120 cases per 100,000. And there is a high rate of TB incidence in these three areas that we were covering. Now, who are we going to screen? Where do we look? Our first step was to look at the hotspots. We mapped the most recent cases that had been notified during the 7 years leading up to our activity. And we began by mapping Caraballo. As you can see, and that is the district that I just mentioned, you can see where the hot spots are, the ones in red, where the most cases were to be found. Now, it's interesting. The areas that are in the dark color were the areas with best access to healthcare. So that was interesting. There was an overlap, and you'll see that described in an article that we're going to be sharing with you. So it's not only the hotspots that need to be covered in our search. Now, how do we do this? We had the experience that I mentioned. We had worked with Karachi, Pakistan, but also we introduced some other variables so that we could detect more. An active search for tuberculosis, the whole idea is to detect in a timely way the highest number possible of persons affected by tuberculosis. So we have different criteria. The radiological criterion, read by artificial intelligence. In the first year, we did 120, 150 x-rays because having an expert to read these x-rays would have taken a very long time. So once they were read, we divided the groups into two, a normal score and abnormal score. For us, a normal score was over 50. To these people, we would take a sputum test for expert. That was a molecular test that we used. And that sputum testing gave us the laboratory criterion, which is also important. And in addition to that, what we have to bear in mind is that if we have an X-ray and a laboratory criteria, we have an epidemiological criterion too, because I said we were working in the red areas, in the hot spots. So to that, we added a clinical assessment. We have the resources available. We had a doctor with all of the criteria at hand, and that person, the physician, decides whether or not this person has tuberculosis. Once the assessment was done by the physician, we have a group of persons affected by tuberculosis, a group with no tuberculosis. The people that were diagnosed with tuberculosis were referred to a care center within their own jurisdiction so as to get treatment started on a timely basis. We started with CAD for TB version 6.0. We used it as of the start. And something was said in the previous webinar about this too. Our first experience was to work with the vendor of CAD for TB to come up with this red curve and to see what the cutoff point was for specificity. And we began with 50. And I said we began because that cutoff point, that often this is a question where everybody asks the same question. What is the best cutoff point? A lot depends on the input that you may have. You have the gen expert, you have other tests. So that cutoff point can guide us. It can give us what is most specific, and that decision depends on the resources that are available. There are different things that have to be taken into account to decide what the cutoff point should be.
Here we have a map of the distribution that we had and some pictures of our mobile unit that we have in our country. One of the lessons that we learned is that although it is true that the mobile unit is much easier, much more practical for us, in order to carry out a campaign and to mobilize everything with the same unit, we also have the digital machine, the digital X-ray machine. We purchased a digital machine that is movable, portable in a way, but it is portable within a unit or within a hospital. It is not the portable machines that we know of today. By 2018, this was the lightest machine available, or at least the one that we knew of at the time. Now we could use a mobile unit with an ultra portable or portable machine within it. It would be much easier. So this is what we had available at the time. We collected the specimen in the same place at the same day in order to get the result as soon as possible. And by having the result, we had to take into account the fact that we had to work with a lab that would enable us to have the results as quickly as possible. We had 50 to 60 specimens a day, and therefore that led to our Partners in Health lab, and they performed all these tests. So we worked for a whole day, 24 hours. We had a morning shift, an afternoon, and an evening shift with a purpose that after 24 hours of having collected the specimen, we would have the results. Taking into account that we started with 2 expert machines that had 4 modules each. Something that I wanted to highlight is the issue of community involvement or engagement. This community engagement, and we have an article that we've placed on this slide, which is to ensure the participation of people. So we raised awareness about TB, and with this awareness raising, we wanted to reduce the stigma because our goals were quite high, and for people to approach us. And I forgot to say this, I apologize, but the people that came to us did not show any symptoms. So having people come to us showing no symptoms was a whole initial problem, because we wanted to see in a way that we could ensure having more than 100 people approaching these mobile units. And that is why we had this community engagement. We're up to date every time we have a campaign. We do this. We have awareness raising 2 weeks before. We start activating 2 days before until the day of the campaign, and we maintain it where we had the intense case finding year. We prioritize this with the social media. We had a line 24/7. We used WhatsApp and updated the information in order to deliver results or any additional query that they might have, not only in case finding, but on TB. This is something that we keep. Here, some more pictures on mapping. And this picture that you see to the left, you will also find that in the relevant article so that you can identify the strategies we use. For every area and every district, the strategies change. So as health personnel, we have to respond to the needs that exist in the community and to analyze what strategies will be used in order to raise awareness and to ensure that the screening is done, to make sure that the screening will be completed, and also to make sure that the treatment can begin. All of this is helped by the community engagement. So how do we find this? So we've been to different places to have an active finding of cases. We had to adapt to whatever we find, as I said previously. And we find some screenings that could be done in the evening or at 9, depending on the population. This is what we had to do, because the people in Peru arrive home at 7, 8 p.m., so we performed the screening like that. So on Sundays, holidays, we also have holidays. We also performed the screening because we concentrated the largest population, and it was precisely the population we wanted to concentrate this on. And these are the first results. We have more than 69,000 people that were screened. 91% of them went through an X-ray. 28% showed abnormal X-rays. We performed 83% where an expert test was performed, because there are always people that cannot leave a specimen. 10% was positive, 14% was resistant to rifampicin, and 393 people were diagnosed with a TB. We use two indicators, key indicators, in order to decide, and this is something that is also recommended by experts, to be able to decide or to assess my performance regarding what we expect, which is the necessary number to screen. And during the first year, it was 148 people to detect one, and 44 experts to detect one person. And here in red, you see something that is really important. There's in 80% of these cases that were diagnosed by expert, but there's a 20% that wasn't. And as what I was mentioning initially, it is important that in the case finding, we detect the largest number of people affected by TB, as many as possible. And that is why the clinical assessment enabled us to detect 20% more of what was expected through an case of finding algorithm in molecular test and AI. The beginning of a treatment was another challenge, because although it is true that we already had some expert machines, not all, and I'm sure that in your countries you have a lot of a rotation of personnel, and therefore the people, when you have to bring in new people, they have to devote their time to being trained with expert. And when the results arrived in the health establishment, they were not acquainted with expert. They didn't know about the AI. And that was another challenge, waiting or not the result from the test. And last but not least, now we have a greater acceptance. As our colleague said, Dr. Valentina will present this through the Ministry of Health. We see many more machines that are now using, so the knowledge of a molecular test in our countries has also increased. And therefore, this challenge that we find during the first year dropped. So what happened then? Well, it happened that our little truck for the first year went up to certain areas, but this is Lima, the human settlements or the slums, as many of you know it. And so the truck didn't make it to all these areas, and we had a highly vulnerable population, which is something to consider, not only the red spots, but also the very vulnerable areas that had to be screened. And therefore, Mochila TV is born. And now I give the floor to Dr. Leo to continue with the presentation. Thank you, Daniela. Good morning. Good day, everyone. The image that you see here, as our colleague was describing, is a typical neighborhood in Lima, where perhaps the poorest, most vulnerable people live in the highlands, and the higher up, the less access to basic services and to access to health establishments. Perhaps that is what they deal with. And so we had to face that challenge. And so the blue truck, many of you have already seen that truck or bus, and it only makes it all the way to where we have some ways, and usually they end where the hills begin. So the question was, how or what do we do in order to make it to the people who live up high, those who cannot come down to the services where we could park these trucks? And that is where a second initiative is developed. And so we're talking about 2020, and this is called the Mochila TB, Backpack TB. This began as an additional activity to TB Mobile, and then we learned another recommendations in use of facilities having portable equipment, easier to move, easier to transport. But at the beginning in 2020, this initiative of Mochila TB or Backpack TB was in addition to TB Mobile activities where TB Mobile couldn't reach, particularly because of geographic access. Next. Then could you go to the previous slide? Simply to highlight something. Many of us now know that we have ultra-portable machines, which are like cameras, very small. But the initial machines, it was not only a backpack. We had to carry like 3 backpacks. And the main one is a picture that you see to the right. One of our colleagues carrying the X-ray machine, which is the echo ray. We see the color of the machine that you see in the bottom picture to the right, but the nest is like a Hawaiiana skirt, all the supports in order to be able to place the machine and to make it operational. So it was not a small backpack. You need several backpacks that have to be moved around and transported, and we have to consider that. Now we already have ultra portable. On this slide, you see a difference between what the advantages and disadvantages are in using one or another equipment. The mobile unit has an advantage because since we have some space aside from the X-ray machine, I have some space where I can carry the printer when we can immediately print the X-ray if the doctor needs to see this physical image or to refer the case to the health center so that they can continue and move on to the next steps. I can also use the space of this truck in order to bring some additional materials. Remember that usually what you put together and what you assemble in these activities are campaigns. So we need chairs and posters and additional materials. And we have the advantage that this truck goes with the electrogen group, and it is important for the equipment. The disadvantage is that it is much more expensive. At the beginning, in order to use the first truck with the X-ray equipment and everything that was needed, it cost us around $180,000, $200,000 for each one of these trucks. And now the prices have dropped depending on the machine that you want to acquire. And obviously, to locate the truck, which needed additional space, we needed to look for sports fields, pitches. We didn't know where to park the truck, and that has the additional advantage that in going from one place to the other one, we only used the ways, the highways, and so we had this advantage of moving this electronic equipment. The backpack obviously is easier to be moved by being smaller. This is equipment that has been developed in order to emit less radiation. The ultra-portable equipment has even less radiation, and this will be discussed when we come to the next webinar. Radiological safety, which is another important issue to be considered. It doesn't need so much space, which is quite advantageous and not having to move the truck around. And since we go to where people are located, it can be used to get into houses where you have people lying in a bed. You can move around in order to take an X-ray, in order to discard TB. The disadvantage is that since I don't have a lot of space, I cannot bring a printer. But there are other advantages. We use tablets where the image goes to the tablet and the doctor can see the image in real time and then be able to decide or make the necessary clinical decision at that time. Also, it needs a point of energy, some power in order to connect the machine. We have ultra-portable machines with batteries, which is also to be considered. And another challenge was licenses. I don't know how you deal with this in other countries, but here in Peru, we have laws and regulations that we can only use X-ray equipment in the community only in situations of emergency. So that has been quite a challenge to get the provisional permits in order to implement these campaigns of finding in the community, active finding in the community. Next. Now, regarding systems and the softwares, AI softwares that we've used since 2019, this has evolved partly because new systems came up, also some additional funding showed up and new pieces of equipment. We have used so far these 3 softwares. We started, as Daniela was saying, using the CAD 40B version 6. We've used it until recently. We've already updated this to version 7. And this system, as you know, gives us a score from 0 to 100, and we made the decision of selecting the cutoff point. And this version 7.0 is much more specific, but it has a lower sensitivity, so we have to be very careful with the cutoff point. In the next presentation, you will hear about the version 7.0, which is being used by the Ministry of Health here in Peru. And another system that we've used is the Cure version 2, which gives us a new score, more qualitative results. Now, in the latest version, they are already adding a numerical piece of information. And the advantage that the system has is that in the latest versions, it gives you information about the other pulmonary lesions, nodules, the presence of nodules, if there are other pulmonary pathologies, which could be important depending on how you are putting together the campaign. And the last one, and the software to the right, is a Lunit, which is a part of the Fujifilm equipment, which has these ultra-portable equipment. We've also used it. We have a couple of these machines, and it also gives us qualitative results. And because of the way in which we use this machine, we prefer to use it when we go to campaigns in close places where we have a population under control. For example, it is very difficult to be able to use a Lunit if you have a mass campaign where people are waiting in order to have their x-rays done. The difference when you have a population under control is that you go to a place where you have 30 people living there, they will not move, and it could work much better to bring this machine. What is important here is that you have to understand how each software works and what version they have, and based on that, you can decide what's best depending on the activity to be performed and what is the best cutoff point that you will decide. Manufacturers help you in deciding what the cutoff point should be. But I believe that someone else explained this. These software have a document that shows you how to select the best cutoff point for active finding. Next slide. This is only a preview. This will be discussed when we come to the next webinar, the importance of deciding a good cutoff point. You will recall in the algorithm, the diagnosis that was shown by Daniela, we found 28% of people that had an abnormal X-ray. If we're doing a screening of 100 people a day, this means that every day we send 28 specimens of sputum to the lab. If, on the contrary, we do 150 or 200 a day, this means that 28% of abnormal X-rays were no longer 28 specimens, and we could have up to 56. So we therefore send an average of between 40, 50 specimens a day to our lab. And this piece of information is important because you have to take into account within your decision-making, what is the response capacity of your labs, whether you will be able to do 10, 20, 30, 40, 50 X a day, expert a day. And it will depend on the number of machines that you have, but also the number of cartridges. So we have a lot of cartridges in Argentina. Maybe you have the possibility of having a significant number of expert assessments a day, but you will run out of cartridges soon. So therefore, we've also encountered a difficulty at times of not having sufficient cartridges, and therefore we analyze the system in order to see how this could vary our detection capacity or not. And this chart shows precisely this. We start off, as I was saying, with a CAD-4TB with a 50. And so we find the 93% of people detected, 64%, 17% of people. This means that I need 28 expert, 28 sputum tests. But if I couldn't do that, one strategy is to change the cutoff point to raise it. If we bring it up, as you see on row 1, the cutoff point to 70, or we consider a score between 51 and 70, but in people with cough, then we are no longer having 28% of abnormal results. According to this estimate, we're going to have 17% of abnormal X-rays. So we're not collecting 28 specimens, but 17. So this is a savings in terms of quantity, but we must also take into account the fact that this reduces our probability of detecting TB using this algorithm. I will not find 100%, but I will bring down the detection capacity to 93%, and so on and so forth. I can add some alternative criteria besides CAT4TB over 70 to consider a score of 50 to 70, but also to consider the age range of people between 15 and 44. I would no longer have this percentage, but it will bring down to 9%. But my percentage and capacity of detecting this was going to drop to 86% using the algorithm. If I decided to bring it from 50 to 70, the score, it was going to come down from 28% of abnormal X-rays to 4%. But obviously, I save in experts because I'm not running 28 tests, but only 4. But my capacity of detecting TB using the algorithm also drops. Therefore, it is important to show that the clinical capacity is key, the capacity of the physician that is making the clinical decision on the diagnosis of TB, because it may be, if I must have physicians, clinicians, epidemiologists, it could increase the possibility of detecting TB. And then what I'm about to present is some of the experiences, the specific and unique experiences that we've had trying to continue answering the questions that my colleague Daniela brought up at the beginning. Where do we look for these cases? Where do we perform the case finding? We know who the well-known risk groups are, contacts of people with some vulnerability in male prisons where we find a lot of TB. But we started wondering, how would this work, this algorithm in active case finding in other groups? And one of the first initiatives that we had, and this was in 2020, was called Warni TB. Warni means women in Quechua. This is active case finding in jails, but jails for women, where the initiatives that we had in Peru with the World Fund and others were only looking for TB in male prisons. So we went with a portable X-ray machine to these prisons for women. And so here we implemented the CURE software, and we used a significant number of TB cases. Out of 2,000 tests screened, and this was in 4 to 5 prisons, women prisons. We found 6 cases of TB, and we found 6 cases with the algorithm. The abnormal chest X-ray that were positive, but 6 additional cases with a radiological clinical diagnosis. Then we continued to think about other groups that could have a high risk of TB, and where we're not finding these cases. One of the activities that we decided to carry out since 2021 was to look in the community of the trans women. In most of the countries, this is one of the most vulnerable communities with the highest stigma that exists. So this was a lesson learned because of the COVID-19 pandemic. We started supporting the Ministry of Health to look for COVID in vulnerable communities. But we found several covers that didn't have COVID. It was discarded, and no one was asking for a sputum specimen to discard TB. And these were the same communities where we always found TB. So we started asking for a specimen of sputum from these people who we suspected had COVID, and we started finding TB cases. And the same thing happened with the trans community. The trans community is a highly vulnerable population, and many a times they live in poverty with high prevalence of HIV. In Peru, we have 20 to 25% of HIV prevalence, and living in an overcrowded situation in the same conditions where we've always looked for TB. But at the beginning, we started joining what is known here as urban mobile brigades. that go to the areas where we find the community of trans women and where HIV is discarded and other sexually transmitted diseases, but no one was asking for a sputum specimen because we could be facing a risk of having TB, and we started finding cases of TB. We found between 300 that were screened, and we found 2 cases of TB, and that told us that there was a problem there, and we had to apply the active finding algorithm in these communities. And I want to highlight the NNS, this thing that was being mentioned by Daniela. What is the yield, the performance? And in order to find 1 case of TB in this community, we had to perform 36 X-rays. And what was important was that around 30% of these trans women did not even have HIV. And in terms of rates, the level of cases is as equivalent or as high as the one we have in many prisons in the region. Next slide. And this is one last experience that we wanted to share. Last year, talking amongst ourselves and the team and with the Ministry of Health, what other population should be screened with a potential risk of having TB? And we had this experience in the Amazon in Peru, in Loreto, on the border with Brazil and Colombia, looking for TB in native indigenous communities in the region along the river, the Amazon River. So we had, it was quite a logistic challenge. We needed to bring the portable machine. We needed to bring the Gene Expert, the machine, to coordinate this and to have the activity, a prior community event to explain to the community what was to be done. And the picture that you see here is a medical ship that already exists from Combined Trust, a Scottish service that goes through these communities to provide medical attention. We joined them to discard the presence of TB, and we found an interesting NNS. 121 X-rays had to be performed to find 1 case of TB. Now we have indigenous communities in Peru that have a high prevalence of HIV, and we are currently discussing this, saying that it would be interesting to have case finding for TB in these communities where we see these problems of HIV. Next. This slide is a summary of where we have been screening over the years, where we've performed this active finding of cases, and we've identified potential groups of high risk. Heading this, we have the males deprived of their freedom with a 22 NNS, and this is an important piece of information. For every 22 chest X-rays, I find 1 case of TB. But secondly, we have women, as I was saying previously, the trans women community. Then we have general populations with a high burden, where we've organized activities at the community level. We've focused some of our activities, obviously, people living with HIV. And this group 5 is an interesting group of an experience that we just completed, because one of the things that we saw is that sometimes having campaigns exclusively on TB poses its challenges. There's stigma. Not everybody wants to come to have TB discarded because of the risk that it being pointed to or stigmatized, saying this person has this disease. So we organized an initiative by adding what we called comprehensive integrated TBs, that is to say, to activate TB more, but not only discarding TB, but to take advantage of these campaigns in order to add the possibility of discarding other diseases for people, not only to have TB discarded with chronic problems, with diabetes, with hypertension, to discard problems of mental health, And that, although it is true, it raised the number of people going to the campaigns, resorting to the campaigns. The challenge that we've faced is that we found many other pathologies. And sometimes we had challenges in order to have one single case of TB, but we would also have to face challenges on how to find people that have other diagnoses and refer them to health services. But it worked. And we found a significant number of TB cases.
In jails, in adolescents in jail, in Native communities, in jails for women. Also, we worked in the area around jails. So around the penitentiaries, there is a whole neighborhood. And often family members move there to be close to the person in jail so that they can visit that person. And we found an interesting number there in terms of NNS. And then also we worked with migrant populations, most of the people from Venezuela, but so far we haven't found as many cases as in other groups. Now, to conclude, we published different articles on this experience. This was published in the Journal of Clinical Infective Diseases, and it talks about not only the classic diagnosis. If we would have, for example, looked for coughing, and if we had done bacilloscopy, we would have only have detected 23% of the TB cases that we were able to detect using this algorithm of CAD. So this is important to understand what the benefit is of implementing these new algorithms. It more or less increases by 4 your ability to detect tuberculosis. This compared to what was done in the past in health centers. Another important thing that we have done in analyzing information and doing some studies, we looked at where we should be looking for cases and how would we do that. This was published in 2022, and it was in Clinical Infectious Diseases. It looks at the use of transportation, and it was found that people using public transportation have an increased risk of TB compared to those that use other types of transportation, taxis, private vehicles. And another important fact is that having been in prison in the past, that is an important fact that can be found by taking a good history. So all of this has helped us with these initiatives. It helps us focus in terms of where we look for tuberculosis, putting the mobile unit at bus terminals, putting them in sites of public transportation, because we think that the possibility of finding TB cases is increased. Now, this is another interesting report. It is something that we analyzed, and it is, where do you look for tuberculosis? At the places where healthcare centers notify more cases. You would assume that in those places they have more cases. Say you have a healthcare center that has 100 cases. Shouldn't I focus on the healthcare center that reports 100 cases? But in this analysis, and it's important to lead this article, what this article says is that notification of cases in healthcare centers is not associated. It's not a good indicator that would help you figure out where to do active case finding. The best thing is to look at socioeconomic status of people. Where there's greatest poverty, it's there that you have to do the active case finding. We found that there are 2 important indicators. Those neighborhoods where there are more cars, where people have more cars, there the risk of tuberculosis is lower. People who have devices. Here we looked at blenders. That is something that we put into our analysis. So the fewer blenders in the neighborhood, the higher the risk of having tuberculosis. So that's very important because it has helped us focus. It has helped us do our active TB case finding, not focusing so much on the health centers, but we had to see how we could get to the poorest neighborhoods. And in part, it was by doing this type of analysis. This is a final article, something that we published this year in the UTLN, the Union, and it shows how radiography helps us diagnose tuberculosis. This is an analysis that we did in Caraballo, and you can see on the left in square A, and this is Caraballo. It has 3 areas. It has an area at the top, at the bottom, and in the middle. In orange, you have the public health centers, and they have X-ray machines. So you can see that at the top, you have X-ray equipment, and also at the bottom, covering their respective areas. But in the middle, there is no X-ray machine. Now, if you look at the right, at B, we added private centers, and there is a privately owned center in the middle that has an X-ray machine. Now, this is important because if we're saying that ruling out tuberculosis, or to be able to rule out tuberculosis, you have to begin with an X-ray. That means that we have to figure out how to give these people access to X-ray machines. Now, we can work with private institutions. We could have a PPP because something like 40% of people that suspect they have tuberculosis, before they go to a public health center, they go to a private center. So here is a possibility for cooperation, and it has to do with access to X-rays. Now, to conclude, these are our conclusions, our recommendations from our experience here. Basically, that active case finding finds more tuberculosis. Now, as everyone says, search and you shall find. So this has to do with morbidity, mortality, the burden of tuberculosis, but there are some challenges. One is you are often serving areas that are beyond where healthcare is usually provided, and it's very important to involve the community so as to reach the areas where you need to be. The most recent experience we have is working with Native and trans communities. The trans community is often mistrustful, so you have to figure out how to work with them so you can get into the areas where these women live, so you can screen them for tuberculosis. Now, attendance to the campaigns, that is high, but again, we need differentiated strategies for populations where access is difficult. And also, there are challenges in guaranteeing that persons diagnosed with TB can begin treatment at a healthcare service. It is important that we look at guidance initially, as my colleague with Daniela was saying, to take a patient that had been diagnosed by X-ray and by a positive sputum test. Sometimes they would say, oh, no, we can't serve this person. You need a bacilloscopy. Without that, we cannot begin treatment. But that has changed. There are new recommendations, and it's easier to do now. And the final message is that the effort to detect TB should be not only to detect and to refer TB cases, but those people that don't have TB but that are at risk should be protected with protective treatment. And we will be discussing that in an upcoming webinar. Thank you. Thank you, Daniela. Thank you, Leonid. Those were very good presentations. I think that this is very useful to be shared with countries that are about to get started with this new modality. First, we have time for Q&A, And we already have some questions that we received through the Q&A. So I would call on Dr. Verkis for her to moderate this session. Yes, thank you very much, Ernesto. Thank you, Leonid. Thank you, Daniela, for that great presentation. All of this is great input and will help other people do active case finding. I'm going to begin with a question from Carolyn Morgado. She says, what is the composition of the teams working with the TB backpacks in communities? Could you tell us how you structured confirmation of the diagnosis? Also, how you combined X-ray with CAD plus molecular testing, and also how you assess the results, if they were positive to the people being screened, and how did you coordinate with health services? I could begin. Well, we had two teams that were divided in the community engagement part. They were made up of community health care personnel, people affected with tuberculosis, and some community areas. They were in charge of engagement, and they did education. They mapped the areas where we were going to be covering, and then they helped us with referrals. So that was one group. The other group was the clinical group. The clinical group was made up of nursing staff that did screening and took samples, also a radiologist. Here in Peru, they're considered a medical technician. That person took the x-rays, and then we had a physician. That physician could be there in person or could be connected virtually for a teleconsultation. And then the clinical team would move in keeping with the places pointed to by screening. Now, there was a second question having to do with, right, returning results, giving them back. As I was saying, we had a WhatsApp that worked 24/7. So as soon as we got the results, for the results that were negative and that did not indicate tuberculosis, the results was returned through WhatsApp or with a phone call. Now, if we could not connect in that way, we would go to the person's place of residence to share the results. If we had detected tuberculosis in the person because of molecular testing, or perhaps with a negative molecular test, but where we felt that there was suspicion, there we would ask the person to come back. Or during the same day, even if we didn't have the result from the gene expert, we would do the referral because we have the epidemiological, the clinical criteria, the radiological criterion too. So the referral was made for that person. And there, that was done with a community agent. And the result of the testing was sent to the healthcare center. It's important to say that it has been very helpful to provide the support, to have a person accompany the person to the healthcare center, because often the people were not following up and getting the care that they needed through the healthcare center. So a community worker can help get that person to begin treatment, to make sure that that person actually did get treatment. In addition to all of that, we had meetings, we gave training to the people working the centers. And as was just said, this was complicated. What we did early on was not part of the technical guidance for TB. So it was an interesting discussion with our colleagues to provide additional information, training. And as I said, all of this has improved over time, especially when the guidelines for diagnosis were changed. Thank you. We have two questions from Antonio Garcia and from Raquel Muniz asking about budgets. about funding and the major source of financing for these interventions. Yes. As I said in my presentation, we started as part of a research project. It was the only way to implement active case finding. And I'm talking about 2018. We applied for funding from the Stop TB partnership, TB Reach, and there we got $10,000 to be able to implement this first phase. That then was complemented by funds from the University of Harvard. Then also we received further funding from Stop TB to work with women's jails. And then during the pandemic, we implemented using COVID funding to justify the need to continue to do active case finding. So if we were already in the communities, if we could find people with respiratory symptoms, we not only looked at COVID, we were also looking for TB cases. And thanks to that, we were able to buy some of these ultra portable devices. Now, also the World Health Organization here in Peru, we are doing educational activities. Let me know if I can help you with anything else. Oh, I'm sorry. Okay, we have another question. Thank you, Leonid and Daniela. We have a question from Raquel Muniz saying, in the Amazon, what has the approach done in terms of gene expert molecular analysis? How and where do you do the analysis? Do you use a mobile lab or do you take it back? Now I'm going to respond to William Cardosa. All of the equipment, the 12 devices available, all work with DICOM formats. Yes, in the experience that we did, we would take a gene expert machine from Lima and we would set it up. We coordinated for those cases detected. The cases detected were sent back to the center, and we had a lot of in-house discussions about how we could take the samples from the place where we were doing the screening to a laboratory in the city. But in this case, it was very complicated because what that ship that I showed you does is it leaves the city, the urban area, and it goes upriver and it doesn't come back for 3 weeks. If we would have wanted to take those samples back to the city, we would have had to hire another boat to run those samples back and forth. Also, there are security concerns in this area, and for all of these reasons, we decided to take the molecular equipment and install it on the ship. Thank you. Thank you, Leonid. Thank you, Daniela. Okay, we will put some of the questions off for the next block. I would ask Cecile if there are any questions, any comments on this first part of our webinar. Cecile? So with that, we can go on to the next segment. I wanted to thank Partners in Health for all this information. I wanted to remind you that these presentations will be available on the drive shared with you by Francisco. Thank you. Now we're going to be hearing from Valentina Alarcón, who is head of the National Tuberculosis Program in Peru. Please go ahead, Valentina. You have 30 minutes. Can you see my slides? Good morning, everyone. I hope that you can see the screen. Yes, we can see it quite well. First of all, I wanted to thank you for this opportunity, the opportunity to be able to share the work that we have been doing with you. We do have a success story to share with you, although we're still working on this experience based on what everyone has been learning. Technology evolves. It's not easy for the countries to adopt technology as part of our program management, but it is possible. And I think that we are all learning and sharing at the same time, and the experience across countries will help everyone improve. I'm trying to get to the next slide. Just a second. Okay. So I'll tell you a bit about background and what I want to tell you about the organization of the healthcare system in Peru. This is important in all countries. You need to know how the system is organized in general and how we, from the programmatic standpoint, have to adjust our operations to that organizational system. We have 8,819 health establishments. We have 19 specialized institutions. We have 133 hospitals and clinics, and we have 26,000 establishments as the total healthcare delivery system. That includes the armed forces. We have the Navy, the Air Force, the Army in Peru. Social Security has 400 establishments, and the National Police in Peru also has establishments, 79 in number. And at all levels, we are working on strengthening our efforts to do active case finding. In keeping with international recommendations, we have both active and passive case finding, and the national system, along with other ministries, our healthcare system is divided into different sectors. We have 5 ministries involved, but in keeping with the law and policies, it is the Ministry of Health that is in charge of determining programs. Now, here on the right, you can see how we are organized within the Ministry of Health. First of all, we are the lead institutions. Then we have the DIDIs, which are more regional. They oversee and make certain that the norms that come from the higher level are actually implemented. There's an executing role that is the healthcare establishment, and the third level of care, that would be hospitals. Also, we have a financial role. That would be the Ministry of the Economy and Finance. They have a method to assign budget, and then MEDIS is another state organization that oversees social programs. It's in charge of PANTEVE, and another source of financing is the World Fund. There, we approve distribution according to the plans, the different proposals received. And then there's a promotional role. This has to do with the healthcare promoters, health promoters, that is private entities, peer counselors, and then we have private entities, local governments, regional governments, and institutions that work with us in all of the activities involved in this program. They continue to strengthen their efforts. We have PAHO, we have Partners in Health. We also work with universities academia makes contributions through their expert committees, but also we have other institutions like the Migrations Office and also the High Commissioner for Human Rights. Here you can see the cases in red. You can see that the cases are going up. These are the cases that are resistant to rifampicin. And what we see, in keeping with what you can see on the screen, what we're seeing is that the cases are actually going up in keeping with these activities of active case finding. This data is not as broken down. Here, you can see the main indicators where we have the greatest gaps. For example, in terms of preventive therapy for tuberculosis, we are at 39.3%. In 2023, we had a cutoff point. Now dropout rate is 34%. And that is something that we think with introducing the new treatment systems, this will improve. And most cases are found in Lima and Callao. 63% are in Callao, and then TB MDR, 77%. And you can see what areas are receiving priority at the national level. There are 12 regions. You can see the map of Peru, all of the eastern area, and then towards the south, and then Lima, Ica on the coast. This is what we have been working on. Now, how do we get started with our active case finding? Just to give you a bit of history, the penitentiaries for some time have been aware of their lack of general health services. But in analyzing rates, what we have found is that the TB rates are high, very much higher than what exists at the national level. And there we use digital radiography. And in this penitentiary population, there were 47,000 people. 1,200 had abnormal chest X-rays, and 1,528 with the abnormal X-rays had a positive sputum with a basiculoscopy, and 177 were found to be rifampicin resistant. So this is basically the work that has been done, not with CAD, not with artificial intelligence, but gradually incorporating molecular testing. Now, the use of portable radiography with artificial intelligence and rapid molecular testing in Peru began in 2020. You can see the different areas, the metropolitan area of Lima, Callao. The financing came from the national program through PP016. The support of the TB Mobile has been provided by Partners in Health. They're our strategic partner, and they have given us support in these interventions. And also, we work with the World Fund. In 2021, the activities were continued. They were expanded to cover other regions like Ica and Lima region. And also, these interventions were done, but also financed by PP016. In 2022, the scope of the invention was broadened further in keeping with the epidemiological situation. We did 786 interventions, and there they were financed by the World Fund, the Global Fund. In the first half of 2023, these community interventions continued, working with specific populations, and I will be covering that later on. But there were also some requests from the penitentiary. So we did 25 different interventions, and that was the Global Fund. Now, in the second half of the year, the intervention did not change. The areas have been identified. We worked with the penitentiary, the penitentiary area, and we receive funding from the Global Fund and also from the state, because part of the equipment, part of the human resources, basic services were paid for by the institution. Now, this plan for active case finding in 2022-2023 aimed at reducing by 10% the TB case detection identified in 2022. And the target population was cases where TB had been detected, healthcare workers, PVs, other special populations. Now, what was the intervention strategy? Obviously, we had to work with DIRIs in the healthcare area so that through this select population that I just described, it is possible to get these people together at one point where we can work with that target population. The healthcare network would assign a space that could be coordinated with the municipality, and the patients were asked to go to that meeting point, and we worked with the local government. MINSA, the Ministry of Health, through national teams, did the monitoring, and this care was provided.
There is a well-established flow, which is the one that we worked on in this intervention flow, that included the use of PPD, the use of digital radiology with artificial intelligence. And at that time, until 2022, we've had version 6. And then obviously the health team that is made up by a minimum physician, a radiologist, a nurse, and someone from the lab, a lab technician, in order to perform the readings and to be able to work and identify the cases. The results of that active case finding, were detected for 53,000 people that came, over 7,000 abnormal X-rays, and 9,497 expert molecular tests were performed. And in addition to what I was saying, radiologies, abnormal X-rays that were detected with AI, because in the team we always have a physician, obviously, who is trained in order to perform the screening also in patients outside the additional tests requested. We found 361 positive experts. Of these, 32 were resistant. And if we talk about a community detection, more or less in proportion, we almost reached 1% of the diagnoses that had been identified. And in total, in the course of these years and in the course of 2023, we found 461 cases. So what is what we have found by way of conclusions or results? The intervention in the community plus additional tests with artificial intelligence, with the use of artificial intelligence, we identified 0.9% of cases. Per 100 to 120 screened, we identified one positive case of TB. We optimized the use of resources during the community engagement. There's a recognition of the norm in force for the use of digital equipment in community engagements, and the target audience at risk was not a closed population or semi-closed population necessarily. It was a population, in quotes, captive, because these were reported cases, and we looked for the contacts, the people that had TB, diabetes, or some comorbidity that could be prone to get sick. We were also asked about the logistic, and so far we've spoken about how we've moved forward in this active case finding. And in the logistic, we have all these materials that you see on the slide. Those that are used to be able to perform these activities, they did move to the point where they were appointed by the regions. We put together some modules which were put together at the right moment, and then to use the equipment we had in electrode group, and that has a cost per intervention, but the basic team are human resources. We have a physician, a surgeon, a laboratory technician, a nurse, biologist, technologist, or lab technician, and a radiology staff, be it the radiologist, a technician, or a medical expert. So these are the resources, and then the technologies used for the active case finding currently are digital radiology equipment, portable equipment, which have been acquired with a global fund. We have 14. The system that is being used is the CAD 4TB, currently version 7, with a cutoff point of 40, which gives us a higher probability of identifying TB cases. And we have been working on this in a timeline. So what is the cutoff point that is going to make us more efficient? And the lab equipment, we're using a Gene Expert with 4 modules and 10 colors equipment in order to detect TB and resistance. So this is the current situation. How are we doing with the current situation in equipment at a national level? We have, in connection with molecular biology equipment, Gene Expert 66 equipment that has been acquired. We should clarify that this has been acquired with the HIV program through the Global Fund, most of them. And the equipment is distributed in Lima, Callao, and the region. 66 equipment. The largest number of equipment is concentrated in the metropolitan area of Lima. And in connection with the portable X-ray equipment, we have 3 different equipments that have been acquired. 7 are in metropolitan Lima, and 7 are distributed in different regions. As you can see on the slide, you can see the map to the right in Loreto, Tempura, Nica, and in the southern part of the country. One of the things that we've seen, and we've had some downsides to it, is to get the authorization of the license for the use of these equipment, and for them to be able to operate in a normal fashion, and that they're regulated by IPEN, which is the Peruvian Nuclear Energy Institute, which is a regulatory agency in our country, which enables us to provide this authorization to these portable equipment. And we have this work that has been done together with the CES, with the Partners in Health team, also with a global fund, to be able to obtain the certification. And the certification is done annually. It is not a license that you're granted for several years. It is on an annual basis. And we have to go through a whole verification process. Even dosimeters in radiation have to be measured as well. When the radiology staff uses the equipment, they have to be renewed. So very well. How are we going to see, or what have we done as results in active case searching in this 2024? By having the analysis at the number of cases identified with that methodology in the 2022-2023 plan, we've seen that we did not have the necessary amount to be able to identify, or where the intervention was the best suited to identify most cases. So we switched, we developed an active case finding for TB for 2024, where, in keeping with the analysis of the information, we have a managerial information system on TB that has been implemented for several years, and it is slightly more robust. We will now move on to a new version where all institutions, all health establishments, be it MINSA or not, register the information there. INPE, the Armed Forces, the PNP, Social Security, all the different agencies, and even some private entities. So on the basis of this analysis, we have set this general objective to strengthen the active case finding in TB and risk groups identified in our jurisdiction as a transmission risk. And we changed a bit to see what was the population where we were going to intervene. And according to this situation analysis that we have, And obviously, we've had recommendations after the visits we received last year. The Bajo Washington Women Commitment and all the high-level meetings that we've held and where the country has committed. In that regard, the risk of populations have been divided into 3 stages. Stage 1, active case finding of TB in penitentiaries, and not only tracing this in the regions where these are financed by the Global Fund, but in all the prisons in the country. And we're talking about 93,000 PPLs approximately as a national population. And we have already begun this active case finding in all prisons with our own budget of La Diresa, and also using that technology, expert technology, and later on we will be talking about it. And during the second stage, which is what we've said, the active case finding of TB in risk population, transport movers, shelters. These are closed populations, universities, health personnel, people with HIV, migrant population, etc. And then stage 3 is the active case finding in communities. So as part of this program, we have the data. These are the data of the penitentiary institutes in the country. 2023. In here, you can see the population in the country and the penitentiary population in the upper right-hand corner of the screen, and how we're doing with the reporting of the cases. As you can see, for INPE, we have 33,883,000. We used an equipment or a team of human resources plus a human resource available in the penitentiary with equipment, digital radiology with AI, and molecular biology teams. And at INPE, we're also working hand in hand with them. And we've introduced this package of software, the CAD for TB, in order to automate the interpretation of the results of this plaque. There are standardized guidelines from WHO on TB, which is Module 2, which is systematic screening of TB, where it is pointed out what the populations are or the specific groups to work on. We have this documented as international recommendations. We have essentially started in prisons and penitentiary centers, but in addition to that, talking about closed, semi-closed, and open populations, we've come into the beneficiency centers at the military forces quarters, and we are working like this, and we must find out and know what the real data are in these closed populations that would imply detecting an initial case, a preventive treatment for TB, because it is not only looking for the case to diagnose and to begin the treatment, but to close the treatment, have a complete treatment, plus the use of TPT, which is the most important thing in order to avoid more cases in the community. So we should talk to the General Director on Health and with a TB team to be able to work on this process. Along the way, there's no internet, as you know, it is a closed population, maximum security penitentiaries, there's mid-level security, but in a coordinated fashion, the level of PPLs that we've been working a day has been 120. And We have worked with the brigades in 2 shifts, IMPE staff proper, plus the brigade that comes in from the intervention in order to work on this. And this is the flow of care that has been provided. There's a waiting room with a delegate from the ward. There's one that is a promoter. There's a record done by the nurse. There's a radiological screening that is performed by the radiology staff. We've also added HIV screening, taking advantage of this intervention. We provide medical care, and we collect the specimen based on the indications, both the intelligence of the results, radiologies with artificial intelligence, plus the clinical diagnosis. On the bottom, you can see the flow screening with AI, with a digital radiology. All those that have a higher score, higher than 40, are immediately referred or sent to collection of sputum. But also those who did not go through this screening will also be assessed by the physician, and the physician, through the interview that is done, how they see and examine the person, also through clinical diagnosis, that they're asked to have a molecular biology test performed, and they follow the sequence. These tests are processed. The penitentiary has the expert in San Juan del Urigancho, and the result, based on the results that we get, the penitentiary entity will also request the second line. Any person in the country is detected with molecular biology, and this test travels to be able to process and identify the resistance to the second line. Thus, IMPE begins the treatment of these patients on the basis of the results and the diagnosis that they have with the resistance test, and they begin the treatment. We've already introduced oral schemes given to IMPE, working with them and training them, training the staff, and also seeing one way or the other that they comply with the treatment. The cases that are IMPE contacts are receiving preventive treatment. The follow-up is done by the health service staff of the penitentiary center, and then we conduct the follow-up for the other cases, or those others that have not been positive for a TB, looking at the differential diagnosis that they have. These are the results that we have from October to December in connection with the sensitivity of radiology and the sensitivity of molecular biology, and the results of the expert. For every 34 X-rays, we found 1 positive case, and for every 7 molecular tests with expert, in this case, we found 1 positive case. We performed the curve to see what the data were showing, whether we were being efficient in connection with having this score on this cutoff point, and the whole analysis was performed. The diagnostic validity of the X-ray, chest X-ray, to determine whether what we were doing as a cutoff point was the best, and it was satisfactory regarding its efficiency, which is what we've been doing. The active search, the active case finding in penitentiary centers to date, we can see some data, 4,930 abnormal X-rays detected from 32,738 PPLs that were screened. Of these abnormal plaques, we processed 5,836 expert tests, in addition to the abnormal X-rays, because of the strategy that I described, where the physician anyway performs a concrete assessment about 100% of these people, those who were not positive for the CAD4 TB, and then he decides whether we perform a molecular test or not. Obviously, we detected out of all these tests, expert tests, 896 positive cases for TB. Yes, positive for TB. And of these, 106 were resistant to rifampicin. 2.8% of the population in the penitentiary have reported cases of TB. The positive level is 3 times more than what we have in the general population, which is what we've seen with the previous intervention. So I believe it's important to perform the analysis in countries of all the information of the epidemiological situation, and in order to optimize the resources, the many or little resources available, to concentrate on where we're going to intervene. As part of the closed populations, we also go to the armed forces, the barracks of the armed forces, the Army in Peru, and the Air Force in Peru. The Army, a military population, has more than 600,000 men. And in that regard, we started seeing the onset of 2 cases of TB in the armed forces. And that led us to having this contact with the Ministry of Defense and to be able to have this active case finding in them. We have visited several barracks. We have the troops that have been screened. We have seen that over 5,000 soldiers have been screened. 38 abnormal plaques is what we got, less than 1%. We've processed 69 samples, and we found 8 cases detected for TB sensitive out of these specimens. And 3 of these cases have been resistant to rifampicin. It has also been said that we have 155 preventive therapies for TB. Of the index cases where they coexist most of the time as part of the troop or part of the barracks where they're launched. So we see that using a plaque, a radiology plaque that cost $1.08 for us, it would be 3.20 soles. A bacilloscopy costs 1 sol 20, more or less. It is profitable because it would enable us to sieve this process and avoid having more cases of TB in closed populations such as the barracks, and taking into account the fact that these soldiers travel because they go to other parts of the country and then they come back. But one of the things that we see is that beginning the preventive treatment in 155 people will prevent us from having TB cases within these military institutions. Then we go to social protection centers, which were these shelters that we mentioned previously. We've covered this 837 people. We've had abnormal X-rays, 173. We've processed samples or specimens in 121 of experts, and we found 3 cases in this population of personal protection centers, which is the data that we've obtained until the cutoff point in May. Now, the results that we see, obviously, if we talk about the NNS for these prisons, we need 36 X-rays in order to find 1 positive case, and we need to perform 6 tests, molecular biology test or rapid molecular test in order to find 1 positive case. And in the prisons, the rate of morbidity is 2,780 cases per 100,000 inhabitants. If we see how we're doing with the issue of shelter, social protection, we've had normal X-ray plaques that you see here, the NNS. We would have to perform 279 X-rays to find 1 case, 1 positive case, and NNT, we would have to perform 40 molecular tests to find 1 positive case. However, the rate that you can see in these shelters as projected would be 358 cases per 100,000 inhabitants. In the armed forces, we have radiological X-rays with artificial intelligence, 694. We found that to be able to see the sensitivity and the detection of TB cases through molecular biology with expert, we needed to perform 8 tests to find 1 positive case. The rate in these armed forces, closed armed forces, is of 143 cases per 100,000 inhabitants. Our national average is 97.6 cases per 100,000 inhabitants. And these are the results that we have so far. The conclusions to deal with prisons, 100% of PPLs were screened, 50% showed abnormal X-ray, 14.4% in prisons have more cases, obviously, as contacts. The mobile radiology with artificial intelligence, which has enabled this percentage of 58% of people with TB not to have any more symptoms. This is what we find in these closed populations, to find cases where they have no symptoms. We can save 80% of expert cartridges, and in S36 to find a positive case, and in T6 molecular test to find one positive case. Sensitivity of the system, the artificial intelligence system, is of 88.4%. And so we're working on plans in order to make it sustainable. What innovative strategies are we using in the active case finding? We're working on a development guideline that is underway. And with what we have learned and what we've been shared from the other countries and from our country itself, which is to implement this strategy of active case finding in communities. It goes through the different phases: organization, execution, evaluation, and monitoring. Essentially, during 2024 and 2025, we have to step this up. There's one phase on organization. We will no longer be in closed populations. We will go to the places where we have the largest number of cases detected, that through the systems that we wanted to identify. And we have been able to geo-reference this also. So in the organization phase, we have to identify the area based on the data available, to meet with them, to visit the field, define the type of intervention, whether it will be mobile or fixed, what resources are needed, the database, how we're going to collect the information, and the execution of the campaign. In the execution proper, we've considered, and I said we're considering because we haven't started this mixed intervention, displacement of the brigades to the point, and also to transfer the people to the fixed point. That there's a satellite point, which is another modality of intervention that will also be done, and an intervention reinforcement in health centers with the necessary conditioning. ¿Podrían apagar el micrófono, por favor? We will look for TB presumptive cases. Obviously, these are areas where we find the conglomerates of TB cases. This is the identification of the community engagement that we've performed as a result of the recommendations that we've received by district, how many cases, what the population is, what the rate is, and to limit where we will have our levels of intervention. We've already identified this all the way to the south to determine the squares, the number of squares, where we've located the largest number of cases in these blocks. We've had the stratification looking at the rate per 100,000 inhabitants, taking into account the number of cases and the population that has been assigned to that place and the number of households. And then to define what is going to be the field of intervention house by house with the brigades. At least we have 10 that will go visit precisely in this area where we have the largest conglomerate of cases, and to be able to identify whether we find more, if the contacts have received TBT, if we have any contact that had begun with respiratory problems that had not gone to the health establishment. So this intervention will not be an intervention from the central level. It is an intervention that follows and will be performed by regional health units with the staff in the health establishment that will have to support these additional brigades, because it is very important for this process to be sustained and supported by the health establishment in the region, and that the information recorded will go to one system, which in this case is the SICTV. To achieve sustainability of these activities, we are soon to approving the technical standard, which is for the update of the technical standard for prevention and control in Peru. And then we've introduced the algorithms for TB, lung TB, passive and active case finding. We described the systemic screening. These are the flows that you can see, the flow charts in the campaign, which has been proposed, and this is for the passive case finding. This is so that these will not be focalized intervention with a global fund, but for the country to take this on as part of the modalities that they have to describe, and that will be mandatory for this to be done, obviously, with additional budgets that we are now requesting. We've asked for an additional demand as Ministry of Health for 2025, which has to do with 53 million to be able to increase this diagnostic coverage, to raise the success rate, to add the preventive treatment, to strengthen the management of the information and prevention and control of TB at all levels, and basically with what has to do with the system of the network of laboratories, we have to beef up supervision and monitoring. So this is what we're requesting as additional demand so far as the Ministry of Health and what has been approved, and we're ready to implement and to strengthen.
Strengthening the primary healthcare level with digital radiography is something that we're working on. We are ordering X-ray equipment, 29 devices that are going to be provided and given to the healthcare centers, and also at the mother and child care centers where there is better infrastructure. There are some third-level establishments that have the conditions to receive this equipment, and also we are asking for them to buy molecular testing equipment using the chip form distributed throughout Lima and Callao, where we have the highest number of cases. Now, in concluding, what are the lessons learned? First of all, strengthening the primary healthcare level, also having decentralization of first level care. That is something that is a recommendation from WHO, and taking into account that these are multiple platforms, interoperability of AI available in a cloud, optimization of information registry, that is essential. And we have learned by doing that we have to improve our information gathering. That is why you cannot disconnect the interventions. There cannot be a parallel system when engaging in this activity. It has to be tied in to the healthcare establishment, and the information has to be recorded in the single system, the SIGTB. Also, we have to optimize resources identified in populations at risk. Also, we have a radiographer that is helping us with this process and working with other information systems that the country has at the INDECIG level so as to help us to better focus. Also, we have to close the cycle of active case finding. We have to close that effort by using preventive treatment. Otherwise, we will continue to have cases. We have to work with many sectors, working side by side. Others have their plans just as we do, and they also are increasing their demands for resources. Then we participate with organized civil society. There are different entities that are supporting us and making these efforts. Then digital radiography that is mobile, and in that way we can reach hard to access populations at risk. We have to be more efficient, and this contributes to decentralization. If we talk about costs, this is better than using molecular tests alone. Molecular tests are expensive, although the cost is coming down, and this is important. We have to assure the sustainability of interventions. Now, next steps: implement the digital radiology network. with CAD at the primary healthcare level. Our intervention is in Lima, Callao, and some regions. We have to train in terms of the management of this system, train general physicians, general practitioners. We have to have an interconnected consultation with radiology services, and we have to do georeferentiation using mobile radiology. This is the central level team and the whole regional national team. Thank you. Thank you, Antonieta. That was a great presentation. And it well complements the presentation made by Partners in Health. Would people please close their microphones? We're going to hear from Paraguay, then we have another Q&A period. And with that, we recognize Sarita Aguirre. Please go ahead, Sarita, and thank you. Hello, everyone, and thank you very much for your invitation. And after these great presentations, let's see what we're doing here in Paraguay. Please keep your microphones closed if you're not speaking. Please let me know if you can see my screen. Please put your slide in presentation mode. Yes, thank you. That's great. Okay, then. Let me tell you about the experience here in Paraguay. And we can look at digital radiology using CAD. Paraguay is a small country compared to Peru. According to our last census, we are 6,100,000 and some thousand. And our annual growth rate is 1.3%. Our life expectancy at birth, 72.33, and public health expenditure on health, 4.12%. And you can see other general data about Paraguay. Okay, here I wanted to show you why we decided to do this type of screening. The population according to the United Nations, we have a population of 6.9 million. And our incidence was 48.8 cases per 100,000. And here you can see the data on the screen. These are the populations where we are focusing our screening. We have 117,000 people that live in indigenous communities, and that is equivalent to 11% of the TB cases diagnosed. And the incidence then would be 310 per 100,000. That means it is 6 times higher than in the general population. And then our population deprived of liberty, more or less 18,000 people. And the percentage of cases, the total percentage, would be 22% with the data from 2023, which means that the incidence, the average incidence, is 4,729 cases per 100,000 population. So we have a large number of penitentiaries where they are even at a higher rate. So here below, we can see the populations at risk. For us, the most important populations are indigenous population and the population deprived of liberty. This is the notification curve of cases. As you can see, there is a significant gap between what is notified and what is expected. But we are improving. We began to do screening in different ways, doing active finding. And at the end of 2020, right in the middle of the pandemic, we had the possibility of each person with symptoms that were respiratory would be tested with molecular testing. And then we included screening using X-rays. In 2022 and 2023, you can see that the notified cases and the estimated cases cross each other. Okay, part of the justification, I already gave you the justification. In June of 2022, we began to do screening, not in an orderly fashion, but we had planned our lack of order. We wanted to see what the situation was like in areas where we had a significant number of cases. And also we wanted to look at the district, at the areas where historically there were no presumptive cases, there were no TB cases. So basically we looked everywhere. And then we analyzed those studies, and there we were able to detect that most of the cases were diagnosed in the penitentiary population and in the indigenous groups. So that became our focus. And we began to focus on them in March of 2023. And as always, sometimes it's hard for us to travel, also because the equipment is here in a central location. So we took the poor areas of Asunción, the central area. That was the area where we saw that, or where we know that 40% of the population of the country lives. Now, as far as national regulations are concerned, we had no major problem in implementing, no problem with the equipment. We did not have the radiologists. The radiologists were hired initially by the Global Fund, then by the ministry, and they had to be trained so that they could have access to the oscimeters. Now, here we had a problem to get that up and operating at a rate of 100%. Now, in terms of implementation, let me tell you what we did historically. We were looking for resources from the Global Fund. Then we saw what Peru was doing with the Partners in Health. So we wanted to thank Leonid because back then he and his team gave us some guidance as we began these efforts. And also we worked with companies, in this case, Fulium, in February 21. They contacted us, and that was February 21. In May 2021, we prepared a proposal going to the Global Fund. So that was basically where we got a small remainder of funds. We prepared the technical specifications, but we never got into radiology there. So we had to study the technical and the administrative components of something of that nature. Then we issued a call for offers. Something like 20 different companies bidded, but what we were looking for, they could not offer. So in a year and a half, we got our first device, our first piece of equipment. And it is a Fuji piece of equipment. And we received training in Spanish. I say in Spanish because here we do not speak English. So it's much easier for us to understand training in Spanish. In English, sometimes we miss a lot of what is being said. Now, in June, we started to work with this equipment, and the cost for us included 3 years of an extended guarantee, $88,000, and we have a representative here. So we have a contact. Sulma is from Paraguay, and Herman Repeto is from the Home Office in the United States. So we also received donations of 2 pieces of equipment through the Global Fund, and we got 2 donations from the Pan American Health Organization and another through a consortium called EOSA, which is a research team made up of researchers from the Netherlands, Paraguay, Portugal, Spain. Within the framework of the research that began in September of 2021, we began to use one of the pieces of equipment, and the equipment that was donated came in February 2023. The cost is between $88,000 and $100,000. What we saw was a bit negative, but we're able to overcome that, and that is that the technical service is remote. We don't have a representative here, so sometimes that takes some time. We don't get a quick response. We have to allow 3 to 10 days to come up with a solution to any minor problems that may crop up. So here you can see Joao's contact information. He's from Delft, and he always is wonderful. Now, what were our logistic problems? As I said, it was hard to prepare that proposal to support our request for that first piece of equipment. We were not acquainted with this new technology, so it took some time. Also, we weren't acquainted with the companies involved in this area, so that took some time. We received some complaints regarding the bids. Also, there was only one vendor in the country, so it was hard to know if the cost was right or wrong. And as I said, our service is often provided in English and it's remote. Both of those things are a problem. Here you can see the 2 brands. We have 2 Delft backpacks. These 2, they were versions 6 and 7. Now they have updated everything to version 7. And this is the Fuji backpack. You can see this picture that I'm sure you've seen many times before, but I just love it. And then planning the intervention, planning the campaign. We always do this in contact with the regional, district, local teams. And as I said, this took some time, but now we are focusing on poor areas, and we always try to take into account the social cultural aspects of each community. Also, we try to let people know well in advance that we're going to be there. Sometimes we use the radio. The whole idea is to get this information out several days in advance so that they know that our screening service will soon be in their community. This is something that I already mentioned, and that is the different services involved in active case finding. In 2016, we began to experience or to experiment with active case finding. And there we looked at the clinical picture. Were they symptomatic? Did we have a suspicion of tuberculosis? If so, we would take a sample. In September 2021, we began with a USEP project that was basically in penitentiaries, and the population was about to leave jail. And we, as a Ministry of Health, since May of 2022, decided to use everything for our screening. Persons that go to healthcare centers, people in prison, people at home, a mass TB screening campaign, and also we work with communities with sporadic activities. So we're especially focusing on indigenous communities and penitentiaries, but we go wherever we are asked to go. Now, with this is data I'll be sharing with you, but this is data that we are gathering from our screening efforts. Now, in terms of people screened, we don't yet have a module. And what is hard is that often we don't have a good internet connection in the field. So we have to fill this information out. Here we have data in terms of the service, the affiliation of the patient, if it's a person at risk or not. Also, respiratory symptoms, signs. We look at the results of radiology, what type of lesions are found and where. And sometimes we take samples, we can take a test, and we use that and we call it epi-info, epidemiological information. Now, the algorithm that we use is a parallel screening, any symptom of TB, and a chest x-ray. If there are TB symptoms, if there are radiographic lesions detected, we will take a sputum sample, and in keeping with that result, we can begin treatment in keeping with bacteriological results. We were working with the team on the cutoff point, and that is something that we're going to be presenting at the next webinar. There, Dr. Medina will be talking about the process to determine the cutoff point. But basically, what we have been doing since 2022, if we found symptoms, we would take a sample. Or if the report was presumptive case of TB without having a percentage as a cutoff point. But after 1 month, or in a month, we will have a cutoff point. And as I said, that will be presented at the next webinar. This was our first algorithm. Actually, it was more a circuit that we established in June 2022, where we took the data, vital signs of the patient, then we would look at HIV, syphilis, diabetes. We would take the x-ray, that was all sent to the physician, and then a sputum test. Now, we always invited the local team to be present for these activities. Also, back then, sometimes we were doing vaccination, we were delivering nutritional supplements to children. So a lot depended on where we were. Sometimes we could incorporate other programs too, and that requires a very large team, 7 to 8 people working from the TB program. Those are people that are part of those activities. So in subsequent stages, we made some changes. There we were focusing on diagnosing tuberculosis, and the local team was doing coverage for other pathologies. So we basically focused on data, we did the serography, and we would gather the data if we found any respiratory symptoms. Then we had another experience. I'm sorry, the music makes it impossible to hear the speaker. And we have 3 penitentiaries where persons deprived of liberty are tested. So to the x-rays, to taking samples for gene experts, we have added tests for HIV, syphilis, hepatitis C, and also the vaccination team. So there's comprehensive care delivered to these people that are just coming into these jails. The idea is to not have TB cases in our penitentiaries. And the people coming in, if they come in with a TB diagnosis, they get treated for TB, or if they're healthy, we give them follow-up so that they will not contract the disease. Now, that activity is quite costly. It's quite expensive, close to $100 for each prisoner, and we are giving them preventive therapy in a weekly fashion using 3HP. Now, here you can see some images from the X-rays. You can see the heat maps, the color maps that we see on the screen. All of this really catches your attention. We don't have lead protection, so we always try to get our X-ray machine at least 10 meters away from people, at least 10 meters away from the people gathering the data or from the population being screened. Now, the results of our search. In 2022, only 2 low burden geographic areas that were not included in the screening. We basically went everywhere else, as I told you. And in 2023, there was only 1 region that we did not visit with the screening mobile. Here you can see the number of visits to each region. Some had visits that lasted 4 weeks, going from Tuesday to Friday. We work with the local team to decide exactly where we're going to go. And in 2023, as you can see, there are more visits. For example, at Central, there were 13 visit weeks. Here you can see another area with 5 visit weeks. And so you can see if there's an indigenous population or the number of people in jail. So in that way, we carry out our visits. You can see the results from 2022. We evaluated 5,502 persons, and 3,494 persons accepted having an X-ray done. Here too, I should say, when we began to work, especially in indigenous communities, we had a significant number of children that would consult us. So in the 2023 stage, we asked that they be over the age of 12. So back then, we had a lot of children and their mothers, and that is why only 71% were screened using X-rays. So without a TB suspicion, 71%, but we found 15 cases in this group of patients, 11 persons deprived of liberty, and 4 from an indigenous population. Where there was a suspicion, there were 972 people, 28.6%, and 64 cases of tuberculosis were diagnosed in this group. And the total number of cases diagnosed back then was 79. And in 2023, 6,385 persons. Here you can see how many are indigenous population, how many are persons deprived of liberty. 95% accepted X-rays, 77% no suspicion, but there we nonetheless diagnosed 38 cases of tuberculosis. With suspicion, we diagnosed 190 cases, so the diagnosis all in all was 228 cases. So here I'm sharing this table with you where you can see by type of population if these persons were TB contacts, if they were persons with HIV, were they deprived of liberty, did they have diabetes, were they indigenous population, or were they children under the age of 15? So here you can see data for 2022, 2023. And when Leonid was speaking, I was doing my own calculations. In 2022, for every 18, we had one case of tuberculosis. In 2023, for 12 NNS, one case of tuberculosis. Now, if you look at the people in 2023, 69 cases, we diagnosed one case. In 2023. For every 28 persons, there was one case. So there's a major difference. When we said that the TB team was going to be dealing with persons over the age of 12. And what we did was work with contacts. In the previous session, we had worked with younger contacts. Now here we see the advantages of using mobile radiology. My colleagues already gave you this information. It is important because we can rapidly see the results of the chest X-ray. It saves costs. We don't need to take a specialist with us to read the X-ray. We can get to very remote areas where the access is difficult. And we can take small vehicles. We have our mobile device, but often they cannot get to these areas, so we use smaller vehicles. And what is important is to think of protection and realize that we're working without a LED screen. The disadvantages, this varies. Often here in Asunción, we can do 30 X-rays over a 4-hour period. But if we go to indigenous communities or if we are penitentiaries, it can be 60 to 120 done by an X-ray device. And the disadvantages, we can do this without electrical connections. We can connect to do the reading, but we try to do that as little as possible. But it is important to have an electrical power source so as to be able to use AI.
We have a printer, but it is so big, and you have to be so careful with moving it that we cannot move it around with all the movements that we have week after week. What we saw also is that during the summer, and this happened essentially with the Fuji equipment, we can't say that it doesn't happen with the others because we were not in extreme temperatures with that equipment, but we reached a temperature of 45 degrees Celsius, and our equipment was overheated, and we had to wait for the afternoon, evening, or night to be able to use the equipment. And by being ultra portable, it is easy to move it around, but there's a risk that you can bump into something and then hit the equipment. As general recommendations, to budget the logistic of the activities, and I mentioned this because we did a lot with a global fund, but currently the Ministry of Health has to cover this, and we don't have the same amount of funds for these activities. So many a times we have not been able to reach faraway places to ensure the maintenance of the equipment, and that guarantee certificate is very important. So not buying equipment without a guarantee of 3 or 5 years. In our case, we wanted to expand this to other services. There's a proposal by the Vice Ministry to acquire 5 pieces of equipment, and that is still underway, to strengthen services so that they will take on the TB screening and to consolidate the strategy, particularly in penitentiary centers and for the Ministry of Justice to be able to adopt this strategy, because from what we see, it does yield very good results. These are just a few images, particularly in indigenous communities. We not always have a roof, or we not always have a comfortable place to organize the activity, but we adapt ourselves. And this is one of the latest visits that we paid to a community known as Maria Elena. It is a port, an indigenous community that is very much in the north of the country, 800 kilometers that we covered by land, and then 90 kilometers in a small piece of land. And we used a little boat that they have with the health authority. And for them to have access to a chest x-ray, they sometimes have to come to Asunción. So when we were there to visit them, they told us that it had been some time where their x-ray equipment was not working, and it is the only one available in that health region. So it could reach more than 80 people with this technology. And so this week we had almost 300 people who were covered by the service. It is a region that does not have a very high incidence of TB, low population density, but we were able to bring this to them. We were able to overcome the difficulties in the road because not everything is covered in concrete. We had days of rain, and so it made it, or it turned it into a different experience to organize this activity. And we even found a friend who was crossing the road. So thank you very much. That is it. And I'm open to any questions you might have. Thank you, Sarita. Very detailed presentation for both countries. We can say that not only Peru and Paraguay are implemented digital radiology with CAD. There are other countries in the region, as is the case with Colombia, the Dominican Republic, Haiti, Brazil, Canada. Some of them are in a research stage, and there's also interest by 7 more countries that have already started to plan the implementation of this technology. So next, we will move on to the Q&A. We have 10 minutes available for the question and answer period. I'll give the floor to Dr. Belkis to select the questions and to give the floor to the speakers for the answers. Thank you very much, Ernesto, and thank you very much, Antonieta Alcon, Dr. Sarita Aguirre, for their brilliant presentations. We have several questions, and they were also asked in the beginning to Peru, but we would also ask Paraguay to answer this question from Raquel Muñiz. And it says, what have been the main hurdles or barriers and administrative limitations to implement mass CAD technology? And Ines, in Peru, specifically in the areas with the largest number of cases, how have you been able to solve this? This is specifically for Peru, but we will ask Sarita to give us an answer also to this question. It seems to me that one of the main hurdles now for us currently is the acquisition of equipment. Currently, in updating the standard, the TB standards, we've already introduced digital radiology with AI and obviously molecular tests as well in a general way. But one of the main problems that we currently face is that we have to complete the procurement of equipment. And with the Global Fund, this is already a good beginning, and this will help us in acquiring additional equipment so that we can expand this in Peru, talking about digital radiology for this to take place. The issue of the license has also been a critical issue because of the provisions that apply in the country. but we are coordinating this with this institution so that we can adjust the standard with a pen, so that we can adjust the standard for these cases where we use portable equipment and where they correspond to this health issues because of these interventions, that we could not make it more flexible, but give it a greatest breadth in order to expedite things and facilitate the authorization, which is what we've had so far. Now, in connection, the infrastructure, we do have to take into account, and we have to visit the health establishment to be able to do the prior analysis. And what do I mean by this? Well, I mean the infrastructure, the spaces, that they comply with the conditions. We're not asking for ambitious spaces, but at least, as I was saying, for the expert issue, what they were requesting was air conditioning and a pit in the ground, which we do need that in order to connect the equipment and have earth power connection. Essentially that, and something else, grounded connections. And something else, another one of the problems that arose in this regard, in INPE, it has been essentially the internet situation. How to use the software without having a power source connection. And that has been with internal coordination with the penitentiary institutes in order to be able to get that, and the organization of the mobilization of the prisoners to the point of intervention, and that has not been standard in all INPEs. Some of the prisoners could leave. They could be moved in one block. Others were moved in groups of 20. Others from 9 to 12 and not 8 to 1 at different times of day. And so we have been able to do that, and we've had to adapt to the organization of INPE, but always coordinating things from the national levels so that we can bring it down to the penitentiary institutes, and thus to be able to perform this activity. Regarding the spaces, in the prior reviews, we've also had to go previously to the institutions to see where to place the equipment, the power source, where we're going to connect things, the spaces, at the waiting room, that entire process. And it seems to me that we've had good opening and good reception for the other places, but in INPE, essentially, since this is a center of security units and shelters, it's been somewhat more complicated, but ultimately we've been able to do it. Thank you, Antonieta. So we move on to Sarita. And let me take advantage of this to ask you another question that is specifically for Paraguay. Could you further explain about the diagnosis algorithm for those who were not suspects of TB with artificial intelligence? Over. Regarding the administrative side of it and having the equipment, the 4 were donated. And the country team, luckily, was supported by the Global Fund. In the first stage, they absorbed both human resources that were initially hired by the fund, and later on they were taken on by the ministry. And then on the logistic, we don't have the amount that we had previously with the Global Fund. So we limit our trips to faraway places. The teams are not in the services themselves. So in the weeks or campaigns we organize, we bring them. Regarding the diagnosis, we get to penitentiaries, for example, or indigenous communities, and we invite the whole population to come to the screening table, to the working table. We take all their data, registration data, and we also ask about TB symptoms, if they're symptomatic or not, if they lost weight, if they ran a fever in the last few weeks. And if it falls within the group of respiratory symptomatic patients, we do take a specimen of a sputum to be processed later on by gene experts, or gen experts rather. And with the Brazilian experience, we usually have this pull up to 4 specimens so as not to use so many cartridges. This is on the one hand if we're only taking a look at the TB symptoms. We also do this on all people coming to the screening. A chest X-ray is performed, and since we do not have an official cutoff point, then we base everything on the Fuji report, particularly when we have a presumptive TB case, when we have a suspicion of TB. If the patient was not symptomatic, but the X-ray indicates a suspicion, we also asked for some specimen through saliva, and so we obtained a few results that bacteriological were confirmed. So that is more or less what we do in almost all active case finding. In the last case finding that we're doing for the new prisons that are now being activated, we're all doing a quantiferon and IGRA, 100% of the people that go there. 102 people so far are those that were screened. And as they go to the new prison, we go through the screening. And we did have 78% of positive results to quantiferon. So practically a good percentage of the people who will be transferred or who are already being transferred, where the preventive therapy will begin. I don't know whether this is clear. Thank you very much, Sarita. It is very clear. Someone, Cruz from Nicaragua, has a question for both, for Antonieta as well as for Sarita. And she gave us 2 examples. Peru did not mention the 80% of savings in expert test doing screening with X-rays. However, Paraguay does contrast this because they did expert for all cases. So she wanted to understand a bit why we have these differences in the decisions between Peru and Paraguay. So we will give the floor to Antonieta and then followed by Sarita. Sarita, would you like to start? Or would you like me to start? Okay, I will start. In fact, the cost of the cartridge, the expert cartridge, is not low if I compare this with a bacilloscopy. This is what we've been doing. What we've done is to establish the cutoff point because previously it was 50, and so we brought it down to 40 to be able to tap more cases or have a sooner detection. So we brought it down to 40 because we also started to acquire more cartridges. For us, for example, an X-ray plaque with artificial intelligence is 0.80 cents of a dollar. And bacilloscopy for the country is 1 sol, a third of the value of a dollar. So that enables us to screen all cases. that are being screened by digital radiology, filtering the cases. And all those that are above 40 have the molecular test performed. And all those who did not go through 40, in any case, we have them checked by the brigade. They always have a physician. They're assessed and evaluated. And depending on the medical clinical criteria, the doctor says that a molecular test is needed. I was talking about the savings because of the amount of population that we are screening. For example, the penitentiary population in Peru, 93,000 TPLs, and 93,000 to perform expert on all of them would not be possible for us because of the amount of cartridges that we've acquired. So we've been increasing this. So we started with 22,000, it went up to 35,000, and then to 50,000. And now this year, we're acquiring 135,000 cartridges. So little by little, we are escalating this. But regarding digital radiology, it seems to me that this is a strength because it enables us to better save, to better identify the suspected case and to them to perform this molecular biology test. So in our case, it was that. Thank you. Sarita? Within the framework of the SAT consortium, we did have a cutoff point of 60. So we only took specimens from those that had that percentage or greater. And for our case finding in themselves, we try to join this platform with a cutoff point, and recently we were able to do it. With the Fuji brand in the general population, we have 25 as our cutoff point. In indigenous population, 35. I'm looking at my blackboard here. And the patients, we lost Sarita. We've lost the connection with Sarita. Can you hear me now? Yes, we can hear you now. Something is failing. I don't have a good connection. So we had recent results with this cutoff point, and this was done recently, less than a month. So as a program, what we did was to take advantage of the fact that we were leaving already and take the specimens according to what I explained previously. And when these were done in penitentiaries, the case finding was done in penitentiaries where we have almost 70% of these people deprived of their freedom when they're symptomatic. We do the poll. What is a poll? It is a process where we pull together the specimens or the lab, but it is not in the lab. So the country pulls together 4 different specimens, obviously, provided that whatever's left, they process specimens for 4 patients and 1 gen expert. If it is positive, then we perform the test on the 4 people to identify who the positive case is. So we use less cartridges, but we don't have any doubts believing that the person who didn't have a test performed could have been a TB case or not. So we don't have as many restrictions for the use of it so far. And that is why we're doing it like that. Thank you very much, Sarita. We do have to clarify something in connection with the poll. It hasn't been recommended so far. We need additional evidence. It is not recommended by WHO. So I wanted to say something about it. This strategy of using the polls is very old. That comes ever since we used these polls for the bacilloscopy. when we were doing research, we pulled together several specimens and then we performed the bacilloscopy. We know that there are several countries in Africa that are using this pooled intervention for experts, and obviously this leads to considerable savings in cartridges. And we have asked WHO, and it hasn't been recommended so far. They're still assessing, they're putting together evidence to see whether they recommend it in these interventions, because it does constitute a significant savings. So that was just a comment that we wanted to share with you. Yes, Ceci is taking note for the purposes of taking into consideration the information for Paraguay that will be part of the NNS. This is information that you have. We have to publish that and to see the results and to be able to develop this in order to have additional information to obtain the new evidence. Belkis, just one thing. We don't do it with all labs. We know how they work, how the different labs work. So it is certain specific places with whom we are conducting this experience, and the rest is a gen expert per specimen. Thank you very much, Sarita. Thank you very much. And we have more questions, but we're running out of time. So what we will do is that those questions that cannot be answered today, we will share in that same link the questions and the answers in a document for each one of the meetings, and so people can review this. So we have the last one for Sarita. If a patient with the PPLs where IGRA was performed, whether an ICAD X-ray was also done, whether a chest X-ray was done with artificial intelligence. Yes, the same schedule that we had followed was applied to see whether they have any symptoms, do the chest X-ray, and then we added quantiferon. This is brand new. We started 10 days ago with these results. So yes, what surprised us there is 12 patients, 12 that were indeterminate, were undetermined with IGRA and have different percentages of X-rays. So we will see, we will ask and find out whether they have other pathologies. They were not HIV patients, did not have diabetes. So we want to see what happened with this group of 12 patients with negative IGRA. In all cases, with a gen expert detected, 8 were positive, obviously, and 1 regrettably, we did not perform any IGRA. Within the 78% that had a positive IGRA, we had the 8 cases that were detected, all sensitive and non-resistant. I just want to clarify one question that they asked about a patient that had caves in the radiology, whether this was confirmed with the recommendations. Of all these tools and screening, it has to be confirmed with a rapid molecular test. We have to use these tools as screening, and the diagnosis will be confirmed with a rapid molecular test as recommended by WHO. I'd like to thank all the speakers, Dr. Sarita Aguirre, Dr. Antonieta Alarcón, Dr. Antonieta, Dr. Puma, all of them for their support and participation in this second webinar. And then I give the floor to Ernesto. Thank you very much to everyone who's participated today. I'd like to reiterate our gratitude to the speakers for their wonderful presentations. And this is a topic of great interest for the region. Over 360 participants all the way to the end so far. And we'd like to invite you to the next session that will be on July 17th, and we will deal with a very important topic that was mentioned today, but not in depth, which is what we need, which is radiological safety. That is a major question that is asked by the countries, radiological safety or security, local regulation, and we will explain how the selection of the cutoff point has been for the active case finding. So July 17th, and we will extend the invitation to all our contacts. And you can disseminate it once you receive it. It will be from 10 to 1 Washington time, similar to today. So we invite you to continue participating in these webinars with the importance required by these topics, and obviously the countries that are very interested in the implementation as quickly as possible to be able to review the technology and then to perform this case finding. I'd like to thank the speakers, the participants, and we'll see you next time. Thank you. Would like to take a picture, if possible, a group picture, if you can open up your cameras. Thank you very much. We're just taking the picture. Thank you very much. Goodbye. Have a good day. Until next time.